This is a talk I gave 4 months ago to the consultants. So the reason I'm going to talk about ultrasound assisted chest drain insertion is because the trust changed their guidelines probably 2 years ago now, actually, about how we should be using ultrasound to assist us with chest drain insertion. So it's just kind of a bit of a brief overview about that, but a lot of this is also kind of revision session or maybe a new session for using ultrasound to kind of diagnose pneumothoraces and pleural effusions as well. Oops, it's not working. 1 sec. Okay, so this is what we're going to be talking about. Hopefully you can recognize the difference between one being a pneumothorax and one being a pleural effusion. Otherwise, we probably need to stop this talk and start doing x-rays instead. Pleural disease is fairly common. We see a fair amount of it. And a lot of it is managed by sticking big, pointy, sharp things into people's chests, which does have an inherent kind of level of danger and safety issues with it. So if we can be safer, we should be. And certainly using ultrasound can allow us to kind of improve patient care and reduce the level of risk. So we'll start with pneumothorax. So for example, we've got a 20-year-old male who's had a couple of days of sudden onset pleuritic chest pain while playing football. The reason he's come into the emergency department today is because he's just not getting any better and started feeling a bit short of breath. Examined him, SATs are okay, respiratory rate's okay, speaking full sentences, but this is his chest x-ray. So hopefully you can see there's a large left-sided pneumothorax. So traditionally we go via this, which is the BTS guidelines. Hopefully you are fairly familiar with this. So this has been around since 2010 and hasn't really been updated since then. So you can see my pointer, sorry. Laser pointer. So this is for atraumatic pneumothoraces. And so, for example, with our patient, he's less than 15, has significant smoking history. We go via the primary pneumothorax route. This, regardless of his symptoms, if it's over 2 centimeters, we would normally go to aspirate. So I don't know how many of you have ever aspirated a pneumothorax. In my experience, 50% of the time it works, 50% of the time it doesn't work, and often you'll then end up needing to go to have a chest drain anyway. So traditionally, this is what we've always done with this sort of patient, regardless of their symptoms, they'd end up having a chest drain. There is this caveat at the bottom, which some people may or may not be aware of, though in large pneumothoraces, it was advised that you could potentially just manage them conservatively. And then there's a bit more recently in 2020, there was a paper that came out that in 2020 wasn't to do with COVID. It was to do with the management of pneumothoraces. So this was a paper that was published in the New England Journal of Medicine, and it looked at conservative versus interventional treatment. So it was based in Australasia, and it was a randomized controlled trial, and it's a non-inferiority trial. So for those of you who aren't aware, a non-inferiority trial, they're taking the proposed new method, be it a treatment or intervention, and they're just trying to show it's not any worse. It doesn't have to be better, it just has to be not inferior. So this is a randomized controlled trial of 316 patients based in about 30 different Australian hospitals, and they randomized half the patients to receive standard of care, which was, so these are patients with large pneumothoraces that would traditionally get a chest drain. So half of them got chest drain, and then half of them were just treated conservatively. So if they came into the emergency department, they were observed for 4 hours, and as long as they weren't desaturating, as long as they weren't very symptomatic, they were allowed to go home. And then they were followed up for the next 8 weeks to see if there was complete lung re-expansion. So their outcomes showed that in the intervention arm, so those that traditionally get a chest drain, 98% had resolution, whereas in the conservative management, 94% had resolution, and their absolute risk reduction was -4. So their inferiority margin was allowed to go up to -9. So actually, this was a statistically significant result. Also, more importantly, in the adverse events, the intervention arm had quite a larger amount of adverse events. As you can imagine, those people getting chest drains more likely to have adverse events. The 13 ones in the conservative arm were all actually patients who failed their conservative treatment and end up having a chest drain. So all the adverse events are actually from patients who ended up having chest drains. So their clinical bottom line is that conservative management is probably as good as a chest drain. It certainly leads to fewer hospital days. The average length of stay for someone who has a holding a chest drain is 3 days, fewer adverse events, and has a lower recurrence rate. So based on that, the Trust changed their guidelines in 2020 to do with both pneumothoraces and pleural effusions, but we'll start with pneumothoraces. So they advised that in hours, all pneumothoraces should be dealt with by pleural fellows. And this is based on kind of a national patient safety alert as well, and a review of our practices. So it kind of makes sense from a safety point of view. If I had a pneumothorax and I needed a chest drain, I'd probably want a pleural fellow who's doing this day in, day out, rather than one of us who probably does a chest drain once every 3 to 6 months, if that. And the pleural fellows can also place a pneumostat one-way valve, so you can actually be managed as an outpatient. Whereas, as previously said, if you need a soldering a chest drain, your average length of stay is 3 days, so it reduces the amount of time you're in hospital. However, out of hours and certainly in emergencies, we as ED clinicians should feel supported to be able to do chest drains. And certainly the last one I saw in hours was about 3 o'clock, rang the pleural fellow, and he had 3 to do in clinic, so asked us to do it anyway. So even in hours, we should be kind of capable of doing chest drains. So this is the Trust guidelines. It looks it's modelled on the BCS guideline. So you can see it's still broken down into primary and secondary pneumothoraces, but the first change you'll notice is that aspiration is now out. Never really worked that well anyway. The second change is that size is less important. It's more now based on symptoms. So for a primary pneumothorax, it doesn't really matter the size. You have to have a pneumothorax over 2 centimeters, and you have to be breathless, or you have to desaturate on exertion. So if your desaturation is down to less than 94%, if you fulfill that, then you go straight to having a chest drain. If you don't, so even if you've got a large pneumothorax, you're clinically very well, if you've been observed for 4 hours, you're allowed to go home, and then you're referred to a pneumothorax clinic. Slightly different for secondary pneumothoraces, so that's still based on kind of size over 2 centimeters and breathless. Any patient who has a total lung collapse, regardless of symptoms, should be admitted under the medical team there. So those are the two of the major changes. But the third major change is also that the Trust now advise using ultrasound to help determine the best site to insert the chest drain. This is what caused a bit of kind of heartache, certainly amongst kind of some of our emergency medicine colleagues, because everyone's not particularly savvy using ultrasound to diagnose pneumothoraces, let alone use it to identify the site for inserting the chest drain. But hopefully by the end of this talk, you'll feel a lot more confident in being able to do that, and it's really not that difficult. So we'll segue a little bit into just kind of how to diagnose pneumothorax to start with. So obviously, I'm sure everyone's fairly competent at being able to look at a chest X-ray to diagnose something like this, a large pneumothorax. However, a lot of patients, especially our trauma patients, will come in lying flat. And if you ever try to look at a supine chest X-ray to diagnose pneumothorax, I'm sure you'll recognise it's not that easy. We also see a lot of patients with underlying kind of chronic lung disease. So if someone's got a large bulla, I'm sure you've seen a chest X-ray, you're not quite sure if it's a bulla or if it's a pneumothorax. Enough to be quite difficult on a chest X-ray. These patients often would go and have a CT. But again, we can use ultrasound instead of a CT to help diagnose this. So if you're going to use ultrasound to look for pneumothorax, I generally use the higher resolution probe, because we're only looking at the pleura, which is probably only a couple of centimeters beneath the skin. And I normally kind of lie the patient flat as well. So air from a pneumothorax is going to rise to the highest point. So generally, if you have a patient lying flat, it's going to be around kind of 3rd or 4th rib space. So I'd normally start with your linear probe, start just below the clavicle, and I'd slide that probe down, looking over 3 or 4 different rib spaces as a minimum. And hopefully, when you look on the screen, this is what you'll see. So the first thing you're looking for is lung sliding. So on the left of the screen, you can see top of the screen is skin, then you've got some intercostal muscles, you've got a rib one side, rib the other side, and this shiny kind of, people describe it as ants crawling across the screen, so it's like a shiny line. This is just your 2 layers of pleura rubbing backwards and forwards across each other. So you have your parietal pleura, which is adherent to your chest wall. Then you have your visceral pleura, which is adherent to your lung. And it's the visceral pleura that's moving backwards and forwards that's creating that lung sliding. So if you see that in that rib space, it means you have a no pneumothorax in that particular rib space. On the left-hand side, the video stopped playing. Let me just go back and see if I can play that again. Doesn't want to play. One second. No, I think it'll play on there's another slide in a minute. So you should see basically the pleural, there's no pleural sliding at this side at all. So because you have air in this area, the ultrasound is coming down and it can't visualize the parietal pleura beneath, which is moving backwards and forwards. Sometimes people find that a bit difficult to kind of think about or visualize. So I've made a nice simple cartoon to kind of make that a bit easier to understand. So imagine this is a rib here, we've got a rib here. We've got the parietal pleura, which is adherent to the chest wall, and you've got your visceral pleura, which is on top of your lung. So normally, without a pneumothorax, as you breathe in and breathe out, that visceral pleura is moving backwards and forwards. And that's what you see as lung sliding. So the ultrasound can come down, go through or bounce off the parietal and visceral pleura, and it bounces back and it sees this lung sliding. If you have a pneumothorax, no matter how big, it could be a very small pneumothorax, could be a very big pneumothorax. You can have air in that pleural space. So even though your lung is still moving backwards and forwards beneath that space, because you've got air or a pneumothorax in that space, the ultrasound cannot penetrate through air. It cannot see this visceral pleura moving backwards and forwards, hence why you lose that lung sliding. So if you see lung sliding in that particular rib space, it means there's no pneumothorax, but it's really important you scan through more than one pleural space. So if the patient's supine, I'd start from below the clavicle, probably come down at least 3 or 4 intercostal spaces to make sure there's no pneumothorax. If you don't see lung sliding, so this is what it should look like before, you can still see some movement here. This is just as the patient breathes, their intercostal muscles are still going to be kind of contracting. So you'll still see movement, but you just won't see this sliding. So if you see no sliding, that can potentially mean no pneumothorax at that level, but it's not 100% specific. There's several caveats you need to be aware of. So if you've got a patient who's hyperinflated, so someone with COPD, someone who's got a lung bulla, or anyone with an acute inflammatory process, be that lung fibrosis or even a pneumonia, you won't always see pleural sliding. That doesn't mean there's not a pneumothorax there. There's several other things you need to look out for as well. So you may see these. So the comet tails and B lines, they are separate things you need to be aware of. So if you ever see a comet tail or a B line, that means the pleura is, there's no pneumothorax. The pleura has to be in, both sides of the pleura have to be in contact with each other to be able to see these. So comet tail, there's these kind of smaller little lines that just come down around 1 centimetre or so, and that's due to the ultrasound beam bouncing between the 2 pleural layers and then bouncing back to the processor, whereas B lines, these larger bright lines that go from the pleura all the way to the edge of the screen, these are due to kind of little pockets of fluid and gas bubbles in the pleura. You see these in other conditions like pneumonia, like COVID, you'll often see these or pulmonary edema. But if you ever see comet tails or B lines, that also means you do not have a pneumothorax at that site. So you can see here, there's no obvious real lung sliding, but because you can see B lines, because you can see some comet tails, you know there's no pneumothorax there. And the other caveat I said, you've got a patient who's not breathing, or you've got a patient who's been intubated and the tube might have gone down the right main bronchus. So if you're looking at the left lung, I'm not sure if you can see that very well, but there's this kind of faint movement of the pleura backwards and forwards, and it's probably going around 60 times a second. So this is called the lung pulse. So you can look at this yourself or on a patient, if you ask them to hold their breath whilst you're looking at the pleural line, there's going to be no movement of the pleura backwards and forwards. Because they're 2 pleural, the parietal and visceral pleura are in contact, you will get this lung pulse. So the pressure, the pulse from the heart is transmitted through your thorax to your lungs. And if your pleura are in contact, as in there's no pneumothorax there, you'll get this kind of lung pulse. So next time you kind of want to try it on yourself or try it on a patient, get them to hold their breath, you should be able to see that. So again, if you see the lung pulse, it means there's no pneumothorax. So to rule out a pneumothorax, you can either look for lung sliding, or you can look for comet tails or B lines, or if you don't see either of those, you see a lung pulse, that rules out a pneumothorax. So conversely, to rule in a pneumothorax, you have to see no lung sliding, you have to see no comet tails or beelines, and you have to see no lung pulse. But to be 100% specific, there's one other finding we can look for. This can help rule in a pneumothorax, and that's called a lung point. So a lung point is the area at which the lung is adherent to the chest wall. So, for example, on the CT scan, if your ultrasound probe is just at this level, on the left-hand side of the screen, you can see there's no lung sliding. And on the right-hand side of the screen, this is the level at which the pneumothorax is. So this is pretty specific for a pneumothorax, although there are some caveats. If you're too, on the left-hand side, if you're too close to the heart, that can sometimes mimic it. And when you come down to the level of the diaphragm, that can sometimes mimic it as well. One caveat to note, though, if you've got a fully collapsed lung, you're not going to see a lung point. So if you think you've got a pneumothorax, you've got no lung sliding, you've got no beelines, comet tails, you've got no lung pulse, but you can't find a lung point, that's probably because you've got a fully collapsed lung, or you're just probably not looking hard enough. So if you don't see it, it doesn't always mean there isn't a pneumothorax, but if you do see it, it's pretty specific for a pneumothorax. Okay, so you've diagnosed pneumothorax, be it from a chest X-ray, be it from a lung ultrasound. The patient's symptomatic, so you feel they need a chest drain. So we can still use ultrasound. This is what the trust kind of guidelines are advising us to do to help assist locate the best place to pop a chest drain in. So traditionally, we're used to using the BTS guidelines, which is a safe triangle. So the most superior part is your axilla, and the most inferior part is your fifth intercostal space. So it's the fifth intercostal space that causes a little bit of anxiety amongst people because it is fairly low. And certainly is a study from 2020 that showed that using ultrasound at the level of the fifth intercostal space, what is the diaphragm doing at that level? So in 81% of patients, in exploration, the diaphragm was below the fifth intercostal space, which is obviously fine if you're going to pop a chest drain in there. In 13%, the diaphragm crossed that intercostal space between inspiration and expiration. And in 6%, the diaphragm was always above the fifth intercostal space. So in about 19% of patients, if you were to pop a chest drain at the level of the fifth intercostal space, there's a chance that you're going to go below that diaphragm and either into the liver or into the spleen. So their advice was that using ultrasound, you can A, identify the level of the diaphragm, and B, should probably actually go above the fifth intercostal space. So to use ultrasound to identify the level of the diaphragm, you're going to change your probe now to a curvilinear probe, and you're going to slide down in that mid-axillary line from the axilla down towards the level of the diaphragm, like that. And hopefully on the screen, this is what you'll see. So you'll see rib, pleural line, rib, pleural line, rib, pleural line, and then you'll get to something called the lung curtain. So as I said, the lung curtain looks very much like the lung point. So this is where you probably want to increase your depth, and hopefully you'd see something like this. So this is this would be on the left-hand side. So this is the liver, and you've got your diaphragm here, and this is a lung coming across. Okay, so this is what we call the lung point, and you want to get the patient to breathe all the way out, so that in end expiration, and then mark this level. So this is the height. This is the highest point the diaphragm is going to get to. So you'd make a mark on the patient's rib at that level, and then you'd use your ultrasound probe to scan back up the mid-axillary line to find the area where there is no lung sliding again. So that would be the level at which the pneumothorax starts. So essentially, on your patient, you're going to have one line, which is going to be the level of the diaphragm. Then you're going to slide back up and find whether there's no lung sliding or whatever, so no beelines, to identify the level of the pneumothorax. And this is then going to be your new triangle of safety. And after that, you can just carry on and do your chest drain as you normally would. So I've certainly done this 3 or 4 times over the last 2 years, and I'd be really surprised that most of the patients you see, actually the fifth intercostal space, the diaphragm, or certainly the ones I did, were at that level or just above it. So it certainly added a level of kind of safety, and actually makes you quite anxious about the kind of chest drains we did previously, and kind of the level of danger was associated with that. So I think if you can, you certainly start using ultrasound to A, kind of help diagnose pneumothoraces, but B, also to identify the level of the diaphragm. And that's what the kind of the trust guidelines say we should be probably trying to do now. So that's pneumothorax, and just quickly just cover pleural effusions in the last kind of couple of minutes. So pleural effusions are fairly ubiquitous, probably see a lot of them. Majority of them, I'd say we don't really need to intervene with. So if the patient's going to get admitted, they'll get kind of seen by the pleural fellow if we think it's kind of a pleural cause. Obviously, a lot of patients who have pleural effusions are due to kind of cardiac failure. If it's a patient we're concerned about and we want to get them reviewed as an outpatient, we can refer them to the hot pleural effusion clinic. So majority of these we won't have to touch at all. In the rare intervention, we feel that there's a pleural effusion that does need intervention. It's generally going to be those patients who are kind of profoundly septic, you're worried about an empyema, or a patient, for example, who's had a pneumonectia on one side and then has a complete whiteout on the other side, and they're extremely symptomatic. So the trust guidelines are actually saying we should be asking interventional radiology to do this. It's probably not something they're going to be doing out of hours, or a clinician trained in ultrasound, which is generally going to be your pleural fellows. But it does have a caveat saying that in a peri-arrest situation, so as we might see a patient in resus, and if they need a chest drain, then it should be someone in the emergency department who's capable of doing that. So just a quick refresher about what a pleural effusion looks like on ultrasound. So you're going to be using your curvilinear probe. You're going to be, again, in the kind of mid-axillary line at the level of the diaphragm, so kind of around your fifth intercostal space. So on the left-hand side, you can see liver here. This is diaphragm. This is kidneys. This is your kind of your classic kind of fast Morrison's pouch kind of level. You've got lung here, and as you can see on this bottom of the screen, this is going to be your thoracic spine. It looks like little kind of camel humps coming up to the level of the diaphragm. And as you can see, above the level of the diaphragm, this spine stops. The reason for being is because your lung is full of air, your ultrasound beam is coming down, hitting the diaphragm, and then hitting air in the lung and bouncing back. Your spine is still there, you just can't see it because the ultrasound is not going to go through air in the lung. As opposed to the one on the right, where you can see the spine continues above the level of the diaphragm. This is called the spine sign. The reason you can see this is because you've got fluid in the lungs. The ultrasound is now able to come through the liver, go through the diaphragm, and instead of air being here, you've now got fluid. So this could be pleural effusion, it could be a pneumothorax. If you've got someone with consolidation, if there's lots of pus in the lung, you can often see the spine sign too. So if you ever see the spine above the level of the diaphragm, that's always going to be a pathological finding. So in this case, you can see there's a very small pleural effusion, so that's not anything we'd ever really want to touch. In the next slide, this is a much larger pleural effusion. So again, your diaphragm is here and your liver's down here. You can obviously see your spine is continuing throughout the thoracic column. You can see that quite clearly. Often people describe as your lungs fully collapsed here. It looks like a wizard's hat. So this may be kind of a size of a pleural effusion you may need to intervene on. So in terms of how to do this, again, the trust saying that all pleural effusions, and also BTS guidelines say that all pleural effusions should be drained with ultrasound. So that can either be ultrasound assisted or ultrasound guided. So ultrasound assisted is much like we would do for a pneumothorax. You'd scan down the mid-axillary line, you'd identify the level of the diaphragm in end expiration, and then you'd identify the level of the lung. So in this example, we'd have the diaphragm at this level, and the lung would probably be about 5 or 6 rib spaces higher. So you'd have 2 marks on the patient. As opposed to pneumothorax, we'd obviously want to go above this level. In a pleural effusion, you want to go between the 2 levels. So that would be a ultrasound assisted. The issue is with this is if you mark it and then the patient moves, or it can sometimes be a little bit dangerous, especially if you've got a small pleural effusion. So ideally, we should be using ultrasound guided. So this is using ultrasound to visualize the needle going into the chest wall in a kind of a live process. So people used to be a bit more kind of apprehensive about doing this, but I think now we're using ultrasound a lot more for vascular access. People are a lot more happy using ultrasound to do kind of procedures, especially things like nerve blocks. It's very similar kind of technique. So you're going to be using a linear probe again, and you'll be using your chest drain. Obviously, you're going to be fully aseptic with a probe cover on, and this is what you should see. So you've got skin, subcutaneous tissue, muscle here. This is going to be your diaphragm. This is going to be your pleural effusion, and then you're going to be using the in-plane method. So you're going to see your needle coming into your pleural cavity here, and then you just carry on with your securing your chest drain as you normally would. So that's how we would advise draining pleural effusions. Again, it's going to be an extremely rare event. It's probably going to be out of hours. It's probably going to be kind of in a semi kind of emergency situation. So it's just something to be aware of and something we should be aiming to do if we can. So in summary, just to rule out a pneumothorax, You can, if you see lung sliding, it means there's no pneumothorax at that level. If you don't see lung sliding, if you see comet tails or B lines, again, that rules out a pneumothorax. And if you've got a patient who's apneic or you've been intubated, you may see a lung pulse instead. And again, that rules out a pneumothorax. So to rule in a pneumothorax, you need an absence of all of those. So no lung sliding, no comet tails or B lines, no lung pulse. And if you can, look for the lung point, because that helps you rule in the pneumothorax. Again, just beware of the caveat that if you've got a complete lung collapse, you won't always see a lung point. Just a bit about infection control. Make sure, obviously, if we're doing chest drains with the guided assisted route, you're using a probe cover. And then in terms of accreditation, there's no kind of formal Royal College of Emergency Medicine accreditation for lung ultrasound yet. Hopefully that might be something that comes in the future. But if you feel you're kind of fairly experienced, you can self-certify, or we can certainly kind of go through a mock kind of patient and you can self-certify and give you a certificate to say, we feel you're happy to do that. If it's something you feel you want more experience with, please get in contact with one of us and we can certainly kind of go through how to diagnose pneumothoraces, look for pleural effusions, and then kind of talk about how we would kind of identify the level of the diaphragm using that ultrasound technique. And I'm sure Michael's going to say a bit more about this in a minute, but we do lots of POCUS at GSTT, as you're probably well aware, so please get involved. There's lots of teaching that goes on a fairly regular basis. And certainly from Monday afternoons, it was something I was doing before the most recent wave, so I'm starting back up again on Monday afternoon. So I think Michael's going to do a bit when he's back as well. So if you want to, it's going to be Mondays from kind of 12 till 5, come for a 2-hour slot. So either send me an email, send me a text. We can sort out some kind of one-to-one teaching sessions for you if you would like. And that's the end. Does anyone have any questions, any clarification points on any of that at all? Happy to answer any questions.
Thanks, Matt. That was great. Anyone have any questions for Matt?
Yeah, I actually have something to ask.
Cool. Yeah,
thanks for the presentation. I think it's very thorough and clarified a lot of things. I was just wondering about the diagnosing of pneumothorax, since I have no practical experience of doing that self yet, but I think I've heard about using the M mode and then these terms like barcode sign and what was the beach sign? Are they
seashore and barcode sign? Yeah, it's something that is taught on. This is just my personal opinion. Other people's opinions may vary. I've seen people make clinical mistakes by using M mode. I think if you keep it simple just with B mode and you're looking for lung sliding, or you're looking for those alternative things like comet tails or B lines, then you don't need to use M mode. I think M mode can confuse people. I think if you're not a regular user of lung ultrasound or using M mode, being able to differentiate sometimes between the barcode sign or the seashore sign or stratosphere sign, whatever you want to call it, can confuse people. And I don't think it adds anything to your ultrasound examination that you get above and beyond using B mode. That's just my personal opinion. I don't know if Michael or Jero, if you have any different thoughts on that.
Yeah, I totally agree. And there are some things you can do to optimize your B mode image. And I just don't think you need M mode. You can see the sliding on B mode if you just optimize your image. So first thing would be using a lung preset. And all our machines have a dedicated lung preset. And if you use the high frequency probe as well, that gives you a depth of at least 6 centimeters, which is usually sufficient to reach the pleura, except in the most obese patients. So if you've got the high frequency probe on a lung preset, and then you bring the pleural line kind of in the middle of the screen, which is where the focal zone will be. And then you can also reduce the gain a little bit because the pleural line is so bright. Sometimes if your image is overgained, like the whole image is too white, it can be hard to appreciate the sliding. But if you just reduce the gain a bit, make the whole image more black, then the pleural line becomes more of a kind of in the middle gray sort of color, and then you can sort of appreciate the sliding better. So yeah, I never use M mode anymore. Cool. Any other questions? Maybe I'll just quickly reclaim hosting rights and just quickly show you what's on the shared drive relating to this topic as well. Feel free to run off whenever you need to, Matt, by the way.
Cool. Thank you, Michael. Cheers.
So this is the shared drive. Hopefully you're familiar. It does take a little bit of navigation. So yeah, first you go to Accident Emergency Protocols. Then you go to ED Clinical, and then Clinical Guidelines. And then you scroll down to ultrasound, and there's an ultrasound folder with lots of subfolders within it. So for chest drain insertion, we do have an SOP, a standard operating procedure for this that we came up with when the trust guideline changed a couple of years ago. So feel free to have a look at this. It just basically spells out everything that Matt's just said. Oh yeah, I'm hoping to get some proper marker pens as well for marking the skin, so you don't have to just use a biro. And so you can have a look at the SOP there, and it's also got an entrustment form if you want to do an actual assessment and be sort of formally signed off in this. Then this is the sort of checklist we go through. But if you've already sort of familiar with using lung ultrasound and you've been already doing ultrasound guided chest drains, you can just let us know and we'll say that's fine. You can self-certify.